时间差不多了，下午还有非常多精彩的演讲，所以我们准时2点开始我们下午的 section。第一个 section 会跟大家谈论到跟一些新的 theranostic tracer 有关的一些 topic. And first, we are very happy to have Professor Watabe to give us a speech about the theranostic targeting of FAP. And let's welcome Director Zheng Meifang and Director He Gongzhi as our moderator. Please.
Okay, 我先用allow me to introduce Professor Watabe first in Chinese, and I will introduce you in English. Okay, 我现在非常高兴邀请到我们那个 Osaka 大学的那个 Watabe 教授。那他是我在疫情之前有幸有去那个日本的应该是放射科年会那遇到的一位非常优秀的一个学者。那当时他就已经在做 FAP 的 tracer， 在一些 preclinical model， 包括 Actinium-225， 还有大家之后看到他的那个履历里面，其实他还有最近发展一些 FOS8 的 FAP 的一些 label tracer。那他也做到了一些 theranostic 一些 model 上面。那趁这个机会，我很荣幸跟大家邀请这个 Watabe 教授来跟我们分享他在 Osaka 大学的一些FAP 相关的一些研究的分享哈。Okay, I'm very pleased to introduce Professor Watabe from Osaka University, and he is a very well-known nuclear medicine specialist, active in the field of immunology and peptide radioligand therapy. And he graduated from the Faculty of Medicine from Osaka University and has his PhD from Osaka University of Graduate School of Medicine. And he's currently the assistant professor at Department of Nuclear Medicine and Tracer Kinetics in Osaka University. And let's welcome him to give us a talk on theranostic targeting of FAP. Please.
Okay. So thank you very much for your kind introduction. So it is my great pleasure and honor to talk in this annual meeting of Society of Nuclear Medicine, Taiwan. So today, I'd like to talk about theranostic targeting FAP. So I have no disclosure regarding my presentation. So at first, I'd like to introduce cancer-associated fibroblast CAFs and fibroblast activation protein FAP. So in cancer microenvironment, cancer-associated fibroblast is the main component, and it is responsible for the cancer progression. So CAFs secrete many cytokines and promote cancer cells progression. And also, it is also responsible for the tumor immunology. So recently, the PD-L1 expression is reported to be observed in the CAFs. So the CAFs are also responsible for the immune escape. And also the CAFs are related to the angiogenesis and ECM remodeling. So it is also responsible for the progression and metastasis of cancer cells. And the important point is the FAP is expressed in CAFs, and its expression was observed in many types of cancers. So it's not limited to one tumor entity. And also, almost no FAP expression is observed in normal organs except for the uterus. And FAP expression was observed in the granulation tissue like wound healing. So sometimes FAP is not cancer specific. So I will talk about this later. So this slide shows RNA expression levels of FAP. So as you can see here, many cancers express FAP. And among them, pancreatic cancer, breast cancer, or lung cancer, head and neck cancer, these cancers show a very strong expression of FAP. And University of Heidelberg groups, they reported the utility of gallium-68 labeled FAP PET in various types of cancers. So as you can see here, strong expression uptake was observed in many types of cancers. And also the physiological expression was minimal in normal organs, except for the urine excretion. So they also reported the FAB values in various cancers. So you can see the many types of tumor shows strong uptake on FAP PET. And some of them shows relatively mild uptakes, but usually the uptakes were higher than FDG PET. So I will show you the detailed cases from now. Dr. Mori from Düsseldorf University, she reported the review in radiology recently, and she said the most of the cancers shows the FAP PET shows a superiority compared to FDG PET for most of the cancers. But some cancers, for example, thyroid cancer, multiple myeloma, or lymphoma, shows the superiority in FDG PET. So recently, there are many reports from China about FAP PET. And this slide shows a comparison of the lesion detection between FAP PET and FDG PET. And for example, in gastric cancer, you can see the FDG PET detects 15 positive lesions, but FAP PET detected 57 regions. And for other cancers, it shows similar trends. So the detection rate of FAP PET is higher than FDG PET. And this JNM paper reported the comparison between the FAP uptake and immunohistochemical staining of FAP. And in the left upper figure, you can see the expression of FAP was variable, but many cancers showed strong FAP expression. And in the right lower figure, you can see the ACV max value on FAP PET clearly correlate with the immunohistochemical staining of FAP. So we can say that the FAP PET detects the expression level of FAPs. And this slide shows a pancreatic cancer case. So the left figure shows FAP PET and right figure shows FDG PET. And on FDG PET, you can see the maybe you cannot see the positive region or the recurrent or peritoneal carcinomatosis of pancreatic cancer. But on FAP PET, you can clearly see the high uptakes of multiple regions. So pancreatic cancer has the abundant of CAFs or cancer stroma. So FAP signal is usually very high. And this slide shows a comparison between the FDG PET and FAP PET. So red color shows the FAP PET outperformed FDG PET. So you can see in many regions, FAP PET is superior compared to FDG PET. But when you look at the primary site, this rate is relatively small. So I will explain the reason later. So the detection rate of FAP is very good, but when you look at the specificity of primary site here, this is FDG PET and this is FAP PET. The specificity is as low as 30% on FAP PET. So why? What is the reason? So the reason is the shown here. So on FAP PET, we sometimes observe the high uptake on the inflammatory regions. It means pancreatitis accompanied by the pancreatic cancer. So you can see in this patient, you can see the primary region in the pancreatic head, also in the FDG PET. But you can also see the strong uptake from the body to tail. So this is a pancreatitis uptake. But this paper says when we scan the delayed phase, we can differentiate the pancreatitis and tumor region. So this is a case of gastric cancer. So among gastric cancer, signet ring cell cancer is very famous for the negative on FDG PET. So this is a case for such negative case on FDG PET, but FAP PET clearly shows strong uptake like this. And when we compare FAP PET with FDG PET for the signet ring cell gastric cancer, you can see the FAP PET is superior for the detection compared to FDG PET like this. So the upper figure also shows the detection on FDG PET is very difficult, but you can clearly see the strong uptakes in the regions on FAP PET. And this is a case of ovarian cancer. So on FDG PET, you can see the very faint uptakes in the surface of liver or other peritoneum. But on FAP PET, you can clearly see the high uptakes on the carcinomatosis. So this is a case of cancer of unknown primary. So when you look at the FDG PET on the left figure, you can see the symmetrical uptake on the tonsils. So usually we assume this is physiological uptakes, and lymph node uptake is very mild, so we cannot say these are malignant. But when you look at the FAP PET, you can see the strong uptake in the right tonsil, as well as the high uptake in the right cervical lymph node. So FAP PET is very useful for the detection of cancer of unknown primary due to the low background signal in this head and neck area. And this is another report. So on FDG PET, you can see the moderate uptake in lymph node here, but on FAP PET, you can see the other strong uptake in the lymph nodes. So we can say that the uptakes on FAP PET is higher than when we compare to the FDG PET in this kind of head and neck cancers. So I'd like to show you two cases, some cases from our clinical research in Osaka University. So this is our initial two cases which we started in Osaka University. So this is lung cancer case. You can see the higher uptakes compared to FDG PET in primary regions. So this patient had no metastatic regions. And right figure shows a gastric cancer case. So this patient is after chemotherapy, and you can see the residual region here on FDG PET, but FAP PET shows more strong uptake like this. So this is a PET CT coronary image. You can, in the same patient, you can see the higher uptake on FAP PET compared to FDG PET. So this is a case of pancreatic cancer, and you can see the primary region here, but on FDG PET, it was very weak, but on FAP PET, you can see very strong uptake. And when we look at the actual PET CT image, you can see very high uptake on the primary side, and also you can see the strong uptake in the metastatic lymph nodes. So on FDG PET, the uptake was very mild. And we also detected the peritoneum dissemination in the pelvic area here on FAP PET. On FDG PET, we can't see any abnormality in this area. So as similar to the reported in the literature, we experience the higher detection rate of FAP PET in pancreatic cancer. And I'll show you another case. This is a breast cancer patient. You can see the very high uptake, even larger uptake compared to FDG PET. And you can see the lymph node metastasis actual area here. And you can also see the very faint uptake in the supraclavicular area. So the primary region is like this. FAP PET shows very high and strong higher uptake. And for actual lymph nodes, you can see a strong uptake. So the lymph node is very small, and the FDG PET shows very faint uptake or almost no uptake. And we can also detect the supraclavicular uptake here. So in the clinical research using FAP PET, we experience a higher detection rate on FAP PET compared to FDG PET. But we need to be careful about the non-cancer region uptake on FAP PET. So the pitfall of FAP PET was reported and shown in this slide. So we sometimes observed physiological uptake on mammary glands or some muscles. And also we often see the uptakes on the bone degeneration in the vertebral joints. And also we can see the high uptakes on the wound healing, especially for the surgery scar. And endometrium shows physiological uptake in female patients. And this slide shows some non-cancer region uptakes. So in lungs, you can see the mild to moderate uptake in obstructive pulmonary tuberculosis. And in vertebra, you can see the moderate uptakes in the small nodes. And in kidney, AML shows high uptakes. And for lymph nodes, we sometimes see inflammatory uptakes in lymph node region. Of course, most of them are lower than malignant metastatic lymph nodes. But like FDG PET, we need to be careful about this kind of uptakes. So in the last part, I'd like to show you about the therapy targeting FAPs. So this is the immunohistochemical staining of FAPs. So in the upper figure of lung squamous cell carcinoma, you can see the strong expression of FAP in the cancer stroma. And in the lower figure, you can see high expression of FAPs, but there are large area of tumor cell clusters. So in this kind of this type of tumor, when we try to treat patient with alpha or beta emitter is better in terms of the penetration length of the emitted beta rays. So recently, many groups are trying to treat patients with beta emitter labeled FAP. So this is a report from India. So they use the lutetium labeled FAP, and they injected this lutetium FAP to aggressive medullary thyroid cancer patient. And before treatment, you can see very large tumor in the neck region. But after therapy, you can see the shrinkage of tumor like this. So there is still a positive region in the neck area, but the patient has a good response to this therapy. So here's another report using lutetium labeled FAP46. So this patient has multiple metastatic region. And upper figure shows before treatment, and lower figure shows after treatment. And you can see in some regions like reverse uptakes, these are decreased or disappeared after treatment. But in some regions, you can see the progression, or you can see detect new regions. So the response is defined as mixed response. So in this FAP therapy, we cannot get the very good results like PSMA therapy. So Dr. Richard Baum of Germany, they performed the lutetium labeled FAPs therapy in a dose escalation setting. And this is uptake image of this lutetium FAP. And you can see the very good uptakes in the multiple bone metastasis and also in the liver metastasis. And he reported that side effects like blood cell count decrease or kidney toxicity is minimal. But for the response in tumors, it's not so good. So you can see the progression in almost half of the patients. So we still cannot get enough treatment effect, at least in the advanced stage of cancer patients. And another group used yttrium labeled FAP, maybe because the penetration length of beta ray from yttrium is larger than lutetium. But the results are almost similar. Half of the patients showed progression. So we need more effective therapy or effective strategy or combination with other treatment. And the reason why the FAP-targeted therapy, radioligand therapy, is not so effective is one reason is the short retention time of the FAP ligands. So recently, FAP46 is mainly used for the diagnosis therapy, but this is a preclinical study, and you can see the gradual washout of FAP compound from tumor regions. And recently, the albumin binder was used to improve the tumor retention like this. And this is a report from China, and they reported good retention in tumor regions in preclinical models. And you can see the good treatment response using lutetium FAP with albumin binder. And our group also tried to establish the effective FAP treatment. And we are thinking of using short half-life alpha emitters. So we use astatine for the main alpha emitter research. And by using the short half-life alpha emitter, we can inject higher radioactivity compared to longer half-life radionuclides. So I think this is good for the short retention FAP. And in Osaka University, we use astatine for refractory thyroid cancer patients. And we are now accumulating patients in a dose escalation setting. And we use this astatine for the labeling of FAP. And we initially labeled two kinds of compounds. And this is a result of preclinical setting. So the results are not so impressive, but we are now optimizing the compound. But I believe the short half-life alpha emitter is can be effective for this FAP-directed therapy. I'd like to explain about the other therapy, non-radioactive therapy targeting CAFs. There are some reports about the CAF inhibition therapy, but most of them are not successfully showed successful results, like amyloid therapy in the brain. So I think the CAF targeting CAF treatment is not simple like cancer cell-directed treatment. So we need more research or other strategy for the CAF therapy. So in conclusions, FAP-PET has a potential to surpass FDG-PET as a pan-tumor probe, especially in pancreatic cancer and stomach cancer. However, we need to be careful about the specificity of FAP-PET since there are some reactive uptakes in non-cancer regions. And for FAP therapy targeting FAP, we need further optimization or combination strategy with other therapy. So I'd like to thank my collaborators and thank you very much for your kind attention.
Thanks, Professor Watabe, for your wonderful talk. Is any question from the audience? I have one question. Professor Watabe, considering the therapeutics, we all hope the FAP will be as successful as PSMA for cancer treatment. However, there is a difference between PSMA and FAP ligand because when the such as PSMA 617 molecule bind to the PSMA receptor, it will be internalized into the prostate cancer cell. However, for the FAP ligand, the small molecule bind to the FAP receptor. It will not internalize to the cell. So it will be dissociate from the receptor. Therefore, the therapeutic effect will be less than PSMA. So we can see the many phase 1 trials, the result of FAP treatment is not so dramatic as PSMA treatment. Therefore, many drug companies design different drug design, such as dimer design of FAP dimer instead of monomer, to increase the affinity and decrease the dissociation. How about your comment and your expectation for the future development of the FAP drug? Thanks.
Okay, so thank you very much for your comment and question. So yeah, I totally agree with your comments. So the in PSMA therapy, the PSM compound was internalized in the cancer cells and stay longer, and it's very good for radioligand therapy, especially for alpha emitter. But in FAP therapy, it's different. So the expression of FAP is observed usually in cancer stroma cups, not in cancer cells. So some types of cancer, like sarcoma, shows expression of FAP in the cancer cell itself, but usually there's no expression. So I think we need another approach. So recently, so today I did not include in my slide due to the time limitation. For example, the drug conjugate FAP with other cytotoxic drugs to cancer cell. That kind of approach is now explored. So I think we need to target or kill the cancer cell via cuffs or using FAP. So that kind of approach will yield maybe good therapeutic effect in the future.
Thanks, Professor Watabe. Is there any other questions?
Thank you. And I have a question that the physiology or uptake of endometrium, is it related to menstrual cycle? And how do you deal with it?
Okay. So actually, I don't know the detail, clear answer. So, but usually the younger patient shows strong uptake, in the endometrium.
Thank you a lot.
Okay, thank you. Well, thank you, Professor Watabe, for the wonderful talk. And I believe that in the future, if we have any questions, he will be welcome to email him or maybe even visit him in Osaka University. Okay, thank you.
Thank you very much.